My name is Dr. Kristen Higgins, and I'm a thoracic radiation oncologist at Winship Cancer Institute of Emory University. I think the answer really depends on the individual patient and the circumstances as to why the patient is receiving radiation. If a patient is receiving palliative bone radiation, for example, and the radiation fields are small and they are not encompassing large amounts of normal critical organs, then typically my practice is to continue the targeted agents during the treatment as there is not likely to be overwhelming toxicity. With any targeted therapy or immunotherapy given with radiation, there is, of course, a risk of potential increased side effects. So that's one reason that some radiation oncologists will consider not continuing targeted agents. If, for example, the radiation field has a very large amount of lung or heart, then those are scenarios where we would sometimes think about discontinuing the targeted agent. But I think it's very important that the radiation oncologist and the medical oncologist have a conversation about the pros and cons of continuing targeted therapy versus stopping the targeted therapy during radiation. And that really depends on a multitude of factors. How long is the radiation course going to be? I think most medical oncologists will have a certain amount of time that they feel comfortable with their patient being off their targeted therapy. And if the radiation course is going to be too long, then that may influence their recommendation. So I think it's really about the radiation oncologist and medical oncologist working together to make these decisions. Now, in terms of immunotherapy has a very long half-life. You can't just, stop it and expect any sort of side effects from immunotherapy to not happen. So it's a little bit trickier when you're doing radiation when a patient is receiving immunotherapy, let's say every 3 weeks. But I will say there is a lot of mounting evidence in the literature that for non-small cell lung cancer, it's generally safe to give, for example, thoracic radiation, palliative bone radiation, even brain radiation during immunotherapy, especially if it's given every 3 weeks. You can come in and do stereotactic radiosurgery in between cycles without overwhelming toxicity. And there's a multitude of retrospective series that report fairly good safety with this approach. So generally speaking, like I said, it's really a decision between the medical oncologist and the radiation oncologist, and it depends on the individual circumstances for the patient.